Okay, welcome everyone to today's Renal Pathology Society Patient Webinar Series. My name is Ben Adam. I'm a pathologist at the University of Alberta in Edmonton, Canada. I'm joined by my co-moderator, Cami Henriksen from the University of Chicago. And I'm just going to start off with a brief intro about the RPS and the series, and then I'll introduce our speaker for today. So the Renal Pathology Society, for those of you that don't know, is a nonprofit organization committed to the improvement and dissemination of knowledge regarding the pathology and pathophysiology of kidney disease. The RPS promotes excellence in diagnosis, fosters basic clinical and translational research, encourages training and education in renal disease, and sponsors international conferences and symposia, and brings news and updates pertaining to renal pathology to its members around the world. So today's webinar is the second in a new patient-centered webinar series sponsored by the RPS. The goal of this series is to further support interactions between pathologists and patients with kidney disease by providing patient-centered educational content focusing on the basics of renal pathology and common glomerular diseases, including IgA nephropathy, FSGS, lupus nephritis, and diabetic nephropathy. So through this series, the RPS hopes to empower patients and pathologists alike, and thus work towards minimizing the burden of kidney disease around the world. So I'd just like to acknowledge that this series is supported by an educational grant from Travere Therapeutics. So we're very grateful for their support. And a couple of quick housekeeping items before I introduce today's speaker. So if you have any questions throughout the presentation, please just enter them into the chat. And we should have lots of time at the end to go through them all. And after the session, everyone should be receiving an invitation to complete a short survey through SurveyMonkey, just to collect your feedback and help us improve future webinars. So please watch your emails for that. Okay, so without further ado, it is my great pleasure to introduce Dr. Carla Ellis, who will be giving today's webinar titled The Pathology of IgA Nephropathy and Its Implications for a Patient. So Dr. Ellis is an associate professor of pathology and lab medicine in the Feinberg School of Medicine at Northwestern University in Chicago. She did her pathology residency training and 2 postgraduate fellowships in medical renal pathology and genitourinary pathology, all at the Johns Hopkins Hospital and School of Medicine. She's a proud alumnus of Howard University, where she was an award-winning athlete on the volleyball team. And a fun fact about Dr. Ellis is that she was inducted into the Howard University Athletics Hall of Fame, and her jersey is currently retired there in the Byrd Gymnasium. Dr. Ellis is now the Director of Wellness, Diversity, and Inclusion, and the Associate Director of the Renal Pathology Service at Northwestern Memorial Hospital. She also serves as the Treasurer for the Renal Pathology Society and as a past chair of the RPS Training Committee. She has a gift and passion for passing her knowledge on to others, and I'm sure she will do an outstanding job of that again today. So with that, I'll pass it over to Carla.
All right, thank you so much, Ben. Everybody can see my cursor here, correct? Just want to make sure. All right, good. Okay, so good morning. It is a great pleasure to be here today speaking to patients about IgA nephropathy. Definitely want to thank Ben and Cami for the invitation and the audience for your time and attention. And I sincerely apologize for that prior cancellation, but happy to be back today to give the presentation now. So one thing I want to clarify before I begin is that the main purpose of this patient series is to give patients the opportunity to hear directly from your pathologist about your biopsy findings. And then we talk about how we arrive at the diagnosis in the pathology laboratory, how we handle your kidney tissue, and we also give some background about the pathogenesis of your disease. So it's a little bit less centered around the treatment strategies for you as a patient and the management, the clinical management of your disease, because your kidney doctors or your nephrologists have that expertise and training. And then we sort of provide the diagnosis that they will subsequently treat. So just wanted to clarify that. And then with that being said, let's roll into the pathology of IgA nephropathy. Before we do that, I want to give a quick outline of the talk. So first, I'll give a brief introduction to IgA nephropathy, and then I want to kind of give the basics of immunology and autoimmunity. Then I'll move on to the pathogenesis of IgA nephropathy and then give some examples of what we see on the kidney biopsy. Then very, very importantly, I want to give a little bit of information about the Oxford classification. It's very important how it's evolved over time and how it's crucial for the management of IgA nephropathy. And then we'll go over different types of IgA nephropathy to include secondary IgA and some other associations with the disease. Then we'll have a quick wrap up and have time for questions. Also, as I mentioned at the beginning, if you have questions, put them in the chat. I have little breaks built in so I can connect with Cami and Ben to sort of answer those if you have something that can't wait till the end. So first of all, I'd like to say that I would very strongly recommend to anyone who missed it to take a look at the inaugural presentation in this series by Dr. Maylin Bissonnette. She gave a wonderful talk about how to understand and interpret your kidney biopsy report, and it is a great foundation for any of these disease-specific talks in this series. She went over the three microscopes, the three types of microscopes that we use to render a diagnosis. And what really stuck with me is her description of immunofluorescence microscopy, because she said that's where the antibody sticks. So given that IgA, for the most part, is a diagnosis that's made by immunofluorescence microscopy, which I'll show and we'll talk about, that concept will be very helpful. So if you have the time and the interest and you're watching this as a recording right now, definitely take a pause and go back and watch Dr. Bissonnette's presentation, because it was wonderful. So IgA is one of the most common patterns of primary glomerulonephritis that has been around since it was first described nearly 50 years ago. And again, that mesangial deposition of IgA is detected by immunofluorescence microscopy, and that finding is the hallmark of this disease. So where the antibody sticks, as Dr. Bissonnette referred to it, is in the mesangial areas. And this is where immune complexes form. And that's how the kidney disease, the hematuria and the proteinuria is manifested. And then again, a lot of what we know about the disease progression and what findings on your kidney biopsy will determine how severe the disease manifestation is based on this previously mentioned Oxford classification, which uses different histopathologic findings that I will discuss to help predict outcome. So I want to give a little bit of background on immunity and how antibodies work. So antibodies are released from plasma cells, usually in response to an injury or an insult, and they're responsible for adhering to foreign material and then identifying it and then recruiting other inflammatory cells and cytokines to come in and dispose of things we don't want or need in the body. So they're composed of two components. There's the heavy chains, which is the pink part of the diagram here, and the light chains, which are the green parts that are attached to the outside. The C on the image stands for the constant region, in which, as the name suggests, it's constant and pretty much the same for all antibodies. The V stands for the variable region. And this is the part of the antibody that is specific for a given antigen. And then you have the antigen binding sites, which are on the external surface out here. And that is where the sites stick to a region of interest. Once this happens, the resulting antigen and antibody complexes are what we refer to as immune complexes. And they're just clusters of antigens and antibodies together. These black bars in the middle are what are referred to as the hinge region of the antibody, which basically are complexes of chemicals that hold the antibody together. So the heavy chains, the light chains, the variable regions, the constant regions are all sort of held together in this hinge region. Now, when I was in medical school, like most medical students, I had to come up with these little mnemonics to remember all the tons of information that we had to get tested on and had to remember. So I came up with GAMED to remember all the different types of heavy chain antibodies. And so, as you can see, IgG is the most abundant antibody in the blood, and its main purpose is to neutralize toxins. IgA, which is going to be important for this lecture, is the second most common and second most abundant antibody in the serum, and it's secreted along our mucosal surfaces, so into saliva and tears and breast milk. IgM is the largest antibody, but it's the third most frequent in the serum, where it's responsible for the early stages of immunity and fixes complement. And then IgE and IgD are very, very limited in the serum, where they are 1 and less than 1%. And they are responsible for allergic reactions, where that's IgE, and then for activating certain inflammatory cells for IgD. So now at this point, you're probably wondering, okay, how is this mucosal antibody that lives in saliva and tears and breast milk causing disease in my kidney? Okay, and we're going to get into that, but first I want to talk a little bit about autoimmunity. So normally, when a foreign substance like a virus enters our body, our lymphocytes and plasma cells create and secrete antibodies to defend us from infection. So as you can see in the image, these white structures are the antibodies that I described earlier that attach to the invader and recruit other inflammatory cells to break it down and kill it and rid our bodies of it. And lately, I'm sure we have all been thinking about and talking about antibodies and their role in defending against coronavirus and, for providing evidence of whether or not we've been previously infected with the disease. But I digress. I just wanted to give an example. In autoimmunity, unfortunately, our own immune systems create antibodies that attach to our own tissues. And this happens for a few reasons. Number one, a foreign substance closely resembles our own tissues and we form antibodies against it. Or, and this is kind of central for IgA, our normal body cells become altered in some way, and then we form antibodies against those. And then the last option is that lymphocytes and plasma cells, the cells that create the antibodies themselves malfunction and then make abnormal antibodies against our own tissues. And again, this is a very, very complex and vast topic, but I just wanted to touch briefly on it at this point because it does have a role in IgA nephropathy. Any questions so far? I know it's really early, but I just wanted to make sure. Anything in the chat?
Nothing in the chat so far.
All right, I'll keep going. All right, so now I know at first glance, this is a terribly busy and complicated image, but the good news is we can ignore the majority of it, and what's left of it, I'll walk us through. So I want to draw your attention to the middle with these red arrows and these dots right here. That hinge region that I talked about earlier is composed of 17 amino acids that are linked in specific areas where the red arrows are pointing, and they're called O-linked glycosylation sites. Okay, to make a very long and very complicated story short and sweet, each of these sites has the capability to extend, for lack of a better term, by these yellow boxes, which are N-acetylgalactosamine, or these blue circles, which are galactose, and then these blue stars. So the yellow boxes can either attach a blue circle alone, or a blue star alone, or a blue circle and then a blue star. Regardless of, and there are several theories about how these different attachment strategies lead to IgA nephropathy, but the bottom line is, if there is an abnormality in this area causing an inability for enough of these blue circles to bind to the hinge region, you end up with what is called a galactose deficient IgA antibody. If there's not enough of these blue circles, not enough sugars in the hinge region, and it's these poorly galactosylated and abnormal IgA antibodies that end up in the serum and circulate and then deposit in the mesangial areas of the kidney. So a major theory in IgA nephropathy is that 2 hits are needed in order to result in disease process. So the first hit is what I just showed, high serum levels of these poorly galactosylated IgA antibodies or O-glycoforms. The second hit is our own autoimmunity. That's when the antigen binding sites of our own IgG and IgA antibodies develop against the abnormal hinge regions because they're poorly galactosylated, and then immune complexes form. And that's when the antigen sticks to the antibody, and then they recruit inflammation together, leading to that glomerular disease. Let's press pause for one moment on antibodies and autoimmunity, and then talk about the structure of a glomerulus, which is the functional part of the kidney. So the glomerulus, which is also called the renal corpuscle, is a very complicated structure that has the main function of filtering the blood of various materials. Some of these materials get reabsorbed later on in the kidney tubules, but what does not get reabsorbed exits the body in the form of urine. So in the top left corner, we have a rendering of the entire nephron, and the nephron is the functional unit of a kidney. At the beginning of the nephron is the glomerulus, which you see here in red, and this blue box around the glomerulus is what's magnified higher here. So the glomerulus has a variety of different parts, but I want to draw your attention to the most important area in IgA nephropathy, which is the mesangial area. So you'll see some purple circles and some arrows labeling them as mesangium or mesangial cells. So these mesangial cells and mesangial areas function to hold the capillary loops together and kind of hold the glomerulus intact. So next are the capillary loops, which are labeled as glomerulus capillary. And that's where the actual filter of the blood happens as it travels through the glomerulus. The mesangial cells are just holding the loops together, and the filter is within these capillary loops. And then lastly is Bowman's space, and you can see that illustrated by the black arrows in the upper right-hand corner. And this is where urine collects before it's filtered. After it's filtered at the glomerular capillary loop, but before it travels down the rest of the nephron. So eventually urine will travel down the nephron, out of the kidney, into the bladder, and then out the urethra and out of the body as urine. So everything kind of starts here at the glomerulus. That prior image that I just showed you was an illustration or a drawing of the glomerulus. And this next image here is an actual photo of a glomerulus with a silver stain. We do a silver stain as part of our light microscopy workup. So this is exactly what we see by light microscopy when we examine your kidney tissue under the microscope. And again, you can see that the mesangial areas are labeled with the M, the capillary loops are labeled with the C. It's a little bit different from the illustration. And then Bowman's space is labeled with this capital B. So now that we have some familiarity with the structure of a glomerulus, let's circle back around to immunology and close the loop on the pathogenesis of IgA nephropathy. So going back to the antibody story, we can see in the upper left-hand corner are a lactose-deficient IgA antibody in light blue. And the red star represents the abnormal hinge region where there's not enough sugar. At step 1, we see our own naturally occurring IgA and IgG antibodies with an antigen binding site that is directed against this abnormal antibody in the upper left-hand corner. This is why I wanted to go over antibody structure and autoimmunity in a little bit greater detail, because it can get a little bit confusing here. So it's like it's an IgA and an IgG antibody that we normally make in the body that is directed against this abnormal IgA. And that's that second type of autoimmunity where our own normal tissue gets malformed, the malformation being the galactose deficient IgA antibody. And then it's kind of IgA attacking IgA. So then at number 2, now you can see the immune complexes that have formed, these clusters of the normal IgA and IgG that have antigen binding sites stuck to abnormal IgA. So at this point, our bodies send out signals to other mediators and like soluble CD89 and fibronectin and other cytokines to recruit inflammatory cells to come in and form an inflammatory reaction. And then at number 3, now that we are familiar with the glomerular structure, we can see here that the mesangial areas between the capillary loops are where these immune complexes get stuck, right in the mesangial areas. And that's IgA immune complex deposition there. And as a result, as you can see at number 4, the mesangial cells proliferate. They increase in number. And they're increasing in number in response to those immune complexes that are depositing there. And then that results in injury to the glomerulus and leakage of blood and proteins, which is called hematuria and proteinuria. Hope we're doing okay. Just interrupt me if there's anything I need to know from the chat.
Nothing at the moment.
Okay, I just want to make sure. Okay, good. All right, so I hope that was clear for everyone. And keep in mind that I'm kind of oversimplifying years and years of very high level research because based on the amount of time that I have to talk about these things, and some of these concepts are a little bit more complicated, but I'm hoping that was a very good generalization of kind of what we know to date about IgA nephropathy.
Hey, Carla, that was amazing. And we actually have panel or audience members saying that everything has been crystal clear. I do have one question now that popped up if you have a moment.
Oh, sure.
One participant is asking, why do these immune complexes deposit specifically to the mesangial areas?
That is a great question. And a lot of the pathogenesis that we know about IgA nephropathy is unclear. We're still sort of just understanding the autoimmunity piece and the fact that those abnormal hinge regions are the antigenic target for our own IgG and IgA antibodies. It's not clear why they're trophic to the mesangium like that and why they stick there. It could be, there's some theories about there's abnormal folding of that hinge region that causes them to get trapped there, or the size of the immune complexes cause them to be filtered there. But it's not an answer it's not a question that has a real clear answer, unfortunately. So yeah, sorry about that. All right, so Dr. Bissonnette spoke very eloquently about the 3 types of microscopes that we use in order to formulate a diagnosis on your kidney biopsy. So our first look at your kidney tissue is in the form of light microscopy. It's a desktop microscope that is most similar to what you see on TV or in a science class or something, but they're a little bit more complex. And here, what we are seeing is the main finding in IgA nephropathy, and that is that mesangial hypercellularity, that proliferation or increase in number of those mesangial cells in response to the immune complex deposition. So if a healthy glomerulus looks like this, I hope that you can see the difference between areas where there are too many cells in the mesangium and areas where there's just kind of diffuse distribution of cells throughout the glomerulus. Hopefully that's kind of clear. The lack of mesangial hypercellularity is up in the upper right-hand corner, and then we can see it here. So I actually should back up a little bit and talk about your actual biopsy tissue when we receive it in the lab. So when we receive it in the lab, it's divided up into 3 pieces. The first piece goes for light microscopy, and that's what I already kind of showed. The second piece immediately gets frozen, okay? And we cut that frozen piece into several thin slices and put them onto differently labeled slides with all the antibodies and proteins seen here. Okay, remember gamed, GAM, we don't really look routinely for IgE and IgD because remember, there's like less than 1% of that in the serum. So we're looking at the common antibodies and then a few other complement mediators. We get antibodies and proteins previously manufactured from drug companies. They're already manufactured. They come with a green light bulb on them, for lack of a better term, that attaches to the antibody and only lights up under the immunofluorescence microscope. So we have all of these slides with all of your frozen tissue on them, and then we pour these manufactured antibodies that are named, as you can see here, onto your tissue, put the cover slip on them, and then look at it under the immunofluorescence microscope in a dark room. So because patients with IgA nephropathy have too much abnormal IgA stuck in their mesangial areas, the green light bulb lights up on the IgA slide the most, and this is what we see. So this would be an example of the slide that has the manufactured antibody on it. And again, the manufactured antibody with the light bulb is sticking to the abnormal IgA in the mesangial areas. And this is how we detect it on your biopsy, and it's one of the key findings in the diagnosis. It's limited to the mesangial areas. You don't see too much green on the capillary loops. That third piece of tissue goes to processing for electron microscopy. And this is a special microscope that goes up to very high magnification. For those of you who have read your biopsy reports or gone over with your nephrologist, you'll see 3 different sections there, one for light microscopy, one for immunofluorescence microscopy, and one for electron microscopy. And this is electron microscopy. So this is high magnification to the point where we're not even really seeing the capillary loops anymore. We're sort of focused on the mesangial area. And in patients with IgA nephropathy, there's dark spots in the mesangial areas, which we refer to as dense deposits. And it represents the immune complexes that I talked about before. These are the exact same immune complexes that we saw in green on immunofluorescence. These are the exact same immune complexes that cause the mesangial hypercellularity by light microscopy. And now we're seeing them in dark gray by electron microscopy. So it's a combination of these findings together that allow us to make the diagnosis on your kidney biopsy. Mesangial proliferation by light microscopy, immunofluorescence, IgA predominant mesangial staining by immunofluorescence, and dense deposits in mesangial areas by electron microscopy. And those are the 3 microscopes. Now, the Oxford classification, very, very important. This is a publication that emerged in 2009 after a meeting of the International Working Group for IgA Nephropathy and members of the Renal Pathology Society. The data in this paper was based on 265 biopsies from 8 countries on 4 continents. And these groups came together and arrived at a consensus classification that did 3 very important things. The first thing is that it helped to classify the histopathologic lesions into defined categories that all kidney pathologists and all nephrologists could agree on and understand, so that the reporting of the disease is uniform for all patients with the disease. The second thing that it did is that it indicated that IgA nephropathy was more than just a glomerular disease in relationship to outcome and progression. So in other words, other parts of the kidney, aside from the glomerulus, are affected in IgA nephropathy. And I'll show that in a second. And then the third thing is it provided what we call a MEST score, an MEST score to a kidney biopsy showing IgA nephropathy. And that kind of goes back to what we talked about on consensus. So making sure that everybody's reporting these biopsies the same way using the same classification system. So the M, the MEST score is divided into 4 components. The M stands for our friend, mesangial hypercellularity, and it's classified based on the number of mesangial cells per mesangial area. So as you can see, less than 4 gives you an M score of M0. Anything greater than 4, basically all the way up to more than 8, gives you a score of M1. These are all, even though there's different numbers here, they're all classified as an M1. The E stands for endocapillary hypercellularity. And that means when we see too many cells inside of the capillary loops, we're no longer talking about mesangial proliferation now. Now we're talking about too many cells within the capillary loops. A little bit easier because if it's present, it's an E1. If it's absent, it's an E0. Just a little bit simpler. It just either it's there or it's not. Doesn't matter how many cells you see. The S stands for any segmental scarring of the glomeruli, like partial scarring of the glomerular tuft. Again, if we see it, it's an S1. If we don't see it, it's an S0. And then the T stands for tubular atrophy and interstitial fibrosis. How much of that is there? This is basically an indication of how much scarring we see in the tubules and in the interstitial supporting network between the tubules. So this is where, as I mentioned before, we're getting away from the glomeruli and looking at other structures in the kidney to determine the progression of your disease. And this score is based on percentages. So 0 to 25% is a T0, 26 to 50% is a T1, and greater than 50% is a T2. So that's your MEST score. So to describe how to apply some of these scores to kidney function, I want to very quickly introduce the concept of slope. Slope, univariate slope, which basically refers to progressive decline of those glomeruli to filter urine over a period of time. So in other words, healthy kidneys filter blood and turn it into urine fast, right? Unhealthy kidneys begin to filter blood and turn it into urine more slowly. And the Oxford classification did the brilliant thing of comparing how fast blood can be filtered into urine in milliliters per minute over a designated time period for a year. So if you have an M0, right, you decrease in your ability to filter blood at the glomerulus by 0.5 milliliters per minute per year. If you have an M1, you decrease even further to 4.2 milliliters per minute per year, slower than you originally were able to filter. If you have an S0, right, absent, similar to the M score, comes down to 0.5 milliliters per minute. If it's present, 4.4 milliliters per minute slower than healthy. And as such, with each progressively more severe T lesion, the kidney slows down by 2.5, 5 in a T0, 5.7 in a T1, and 11.1 milliliters per minute slower in a T2 lesion, right? So to summarize, as the severity of your lesions increase in IgA nephropathy, the ability of your kidneys to function and filter effectively decreases. I hope I've explained that, okay? And just in case you were wondering, in the original iteration of the Oxford classification, the E score, the endocapillary proliferation, wasn't statistically significantly predictive of the rate of renal function of decline. So everything here has a p-value of less than or equal to 0.001, and the E score didn't do that. We still report it, we still talk about it, and it's still part of the MEST criteria, but I just wanted to let you guys know why it isn't on this particular figure. Okay, let's talk about crescents. Crescents are a response to glomerular injury. Okay, I love starting off with an illustration. Looking at this illustration, we see our mesangial cells, right, that are increased in number and proliferating in response to the immune complexes. And then we have associated injury to the capillary loop, which causes focal disruptions, allowing leakage of fibrin and other irritants to those cells that are lining Bowman space. That in turn irritates those cells and causes proliferation. When those cells start to proliferate more and more, they press down on the capillary loops and on the mesangial areas and cause more inability for the kidney to function improperly. So here's light microscopy. We can see crescents in a lot of different glomerular diseases, and that includes IgA nephropathy. So here by light microscopy again, we can see the histologic image of what I just showed in the illustration. We've got the proliferation of these cells that are outside of the glomerular capillary that are pushing it over to the side. And sometimes you can even see the individual fibrin strands by light microscopy in between these proliferating cells. And the longer the crescents are there, the older they get, and they become less cellular and more fibrous as they age. So the fresh ones are called cellular crescents, and then the older ones are called fibrocellular crescents, such that later, in the original Oxford classification data system, crescents, along with that endocapillary proliferation, weren't found to be as predictive of outcome. But then a few years later, in a subsequent larger and more broadly based cohort of patients, it was determined that crescents actually are very predictive of outcome, and they commonly increase the severity of glomerular disease, specifically IgA nephropathy. So it was recommended in this publication that the Oxford classification be updated to include the C score, the C meaning crescents. So as such, C0, no crescents at all. C1, cellular or fibrocellular crescents present in at least one glomerulus. C2, same thing in greater than 25% or more of glomeruli. Such that because crescents are severe to the disease process, their presence tend to indicate a response to treatment. So that a C1 score identifies a patient at risk of a poor outcome if not given immunosuppressive therapy. A C2 score identifies patients at risk of a poor outcome even if given immunosuppressive therapy. So the second 2016 version of the Oxford classification didn't do as much with the slope and the decrease in milliliters per minute per year, because that data was already established. They looked at a broader cohort of patients and looked specifically at the number of crescents, which is why we're saying 1 versus greater than 25 versus 0, and whether or not the patients had been on immunosuppressive therapy. So that's the beauty of these Oxford classifications. They're taking A, the biopsy findings, combining that with B, the known outcome of these patients, and then kind of retrospectively looking back and saying, this is, if these particular findings are seen in the biopsy, this is how the patient does. If the patient is on this particular treatment, this is how they do long term. And a lot of statistical number crunching was done, and this is how they came up with this information. So that's your MEST-C score. Anything? Just another break.
No, everyone is responding very positively. One participant said, "Great explanation of Crescents. First time I understand this so clearly." So you're doing a great job of explaining everything. It's wonderful.
Thank you so much. Thank you so much. I love hearing that. All right. So yes, Crescents, and I can't emphasize enough how much this classification system helps us as kidney pathologists, because it makes it easier for us to say, hey, this is IgA nephropathy. I've already determined that by my immunofluorescence, my electron microscopy, and my light microscopy. Now, let me take this a step further and calculate this data into a classification system that everybody uses. Uniformity. Okay. So when we talk about secondary causes of renal diseases, what we mean is that another disease process happening in the body causes deposition of IgA into the mesangial areas. And there are a lot of theories about how this happens, but some of the more common ones, some of the more common primary diseases that cause secondary deposition of IgA in the kidneys are listed here. So liver disease, big one, most common cause of secondary IgA deposition. People with alcoholic cirrhosis have abnormally glycosylated IgA in the serum, which leads to IgA deposition in a fashion similar to what I described earlier. It's going to be the same for most of these. Infections, hepatitis, that liver disease also causes abnormal deposition of IgA in the kidneys. Mucosal inflammation, so your inflammatory bowel diseases, ulcerative colitis and Crohn's disease. If these patients all of a sudden start developing proteinuria and hematuria and a kidney biopsy is done, we definitely need to know that information that they have these inflammatory bowel disease, because this is probably going to be secondary onset of IgA. The mechanism, the direct mechanism in these inflammatory bowel diseases has, according to this paper, been kind of yet to be elucidated. A lot of what IgA we still kind of don't know. But if we know that IgA is a mucosal antibody that lives on mucosal surfaces, and then all of a sudden this becomes completely inflamed because of these diseases, it's likely that there's increased production of abnormal variants of IgA, which then deposits in the kidney in the same fashion that we kind of saw before. Other autoimmune diseases, people with rheumatoid arthritis have elevated levels of abnormal IgA in the serum. And then sometimes there's cancers, mostly lymphomas. And there's a special lymphoma called a MALT, a mucosa-associated lymphoid tissue or lymphoid tissue lymphoma that is commonly associated with a secondary onset of IgA. So it's always a possibility when we make the diagnosis on a kidney biopsy of IgA nephropathy that there's a possibility that's a secondary onset. So we raise that possibility, but we always do that after a careful review of clinical history and after a conversation with your nephrologist to make sure that you don't have these other diseases. Because we're not really seeing you as a patient, we're mostly just looking at your kidney biopsy tissue. So, and IgA can be seen in combination with other diseases. So I borrowed this slide from Dr. Markaz at Cedars-Sinai, and he has studied IgA nephropathy for many, many years. He was one of my mentors at Johns Hopkins in renal pathology, a big reason why I wanted to choose renal pathology as a career subspecialty. And he was also an author on both the 2009 and the 2016 Oxford classification publications. So, so as I discussed, we'll see what Dr. Haas has to say here. IgA nephropathy can be either primary, secondary, or familial. Okay, it's very, very common in Asian populations. In adults, it's usually limited to the kidney, right? But in children, it can have a systemic onset that can affect the whole body. And it's usually in organs or vessels of other organs, most commonly the skin, which presents as an IgA vasculitis. Other renal diseases that have mesangial deposition of immune complexes need to be ruled out before you make a diagnosis of IgA nephropathy. So he says lupus and C1q nephropathy and HIV-associated lupus and those kinds of things where there's a lot of deposition of those dense deposits in immune complexes in the kidney, want to make sure that we rule that out. Okay, and then IgA dominant post-infectious. So you can have IgA can be associated with staph infections and be combined with other kidney diseases like post-infectious glomerulonephritis. You can have IgA and post-infectious kind of in the same biopsy. And then there's always these mixed lesions like IgA nephropathy with other kidney diseases and latent deposition of IgA. So the first biopsy may not show any IgA deposition, and then the patient sort of progresses. IgA is very indolent. You know, it takes a long time to get to kidney disease, and in most cases. So it could be that you may have had more than one kidney biopsy, and the mesangial IgA deposits didn't show up until sort of a later biopsy. This last slide is what I use when I'm teaching medical students about IgA nephropathy. I'm sure it should be clear by now that this is very, very complicated, complex material. So I think it helps, at least I know what I did when I was in medical school, to have like an illustration and sort of a comedic kind of humorous aspect to it to help you remember all of the mechanisms of all these diseases. So at number one, we have our formation of the galactose deficient IgA. So there's our galactosis that's missing. And so the plasma cell says, I feel like she forgot to add more sugar. Actually, the IgA antibody says that to the plasma cell. And then in two, we get the formation of our autoimmunity, those IgG and IgA antibodies that, you know, he's saying, sorry for being less sugary. And then the IgG is going after him. IgA2, just not pictured in this cartoon. Those complexes circulate through the blood, deposit in the kidney, cause mesangial deposition and activation of complement, which results in injury to the kidney, injury to the glomerulus, and loss of hematuria, loss of blood and protein, which are referred to as hematuria and proteinuria into the urine, which is a common presenting symptom for IgA nephropathy. So as I wrap up here, I want to definitely thank Doctors Adam and Henriksen, the procurers of this renal pathology patient-based lecture series. Thank you so much for the invitation and for the opportunity to speak on this disease. Dr. Mark Haas at Cedars-Sinai, who is just a wonderful, wonderful person and inspired me a lot to study kidney pathology. Mr. Raul Suarez, who is our renal pathology information technology expert, helps to make things run so smoothly. And most importantly, all of the patients, your biopsy material has contributed to years of dedicated research and a much better understanding of this disease. So thank you so much for your time, and I'll definitely take any questions that you have.
Thank you so much, Carla. That was such a great talk. Targeted towards all different levels. It was wonderful. We do have a number of questions if you have a few minutes. First of all, okay, in the Q&A, we have Reem asks, to calculate the C-score percentage, do you need to count all glomeruli, or do you need to count all glomeruli, or do you exclude the sclerotic ones when you're calculating the percentage?
I use all of them. I count all of them, even the sclerotic ones. I know that they're not functioning, but they're still glomeruli. So I use all of them when I calculate that. So, you know, if you have 10 and you have 3 crescents, then you got 30% crescentic change, and that would be a C2 score over 25%.
Okay. Mm-hmm. Excellent. Next question. What would be the potential mechanism for the development of IgA nephropathy in patients using anti-TNF alpha drugs?
Anti-TNF alpha drugs. I don't know that I know the answer to that, the mechanism for that. I would imagine that anti-TNF is an antibody. Maybe there's some sort of overlap or some sort of effect on the normal IgA antibody that causes the decrease in glycosylation? I don't know. I don't have a good answer for that.
Right,
I'm gonna find out and get back to that.
We'll do our homework here. Or maybe it's the underlying condition that they're being treated for with the anti-TNF alpha drug that is actually.
Yeah, that's a good thought, Cami. It could be a secondary onset of, and like we said, as far as I know, anti-TNF is that a immunotherapy or a chemotherapy for malignancies?
Immunotherapy, I believe, for certain autoimmune diseases.
Yeah, well, that
could be the autoimmune disease
that we talked about can cause a secondary onset. So
right.
not sure a lot has been looked into on that, but that's definitely a good theory.
Yeah, interesting question.
Yeah.
How frequently have you diagnosed IgA nephropathy without the presence of significant C3 staining by immunofluorescence?
Not commonly. It's usually, and that's what I was going to go into that when I talked about immunofluorescence, but I didn't want to take too much time or make it too complicated. You usually have, it's not usually IgA dominant, it's usually IgA co-dominant by immunofluorescence. So you will have some staining with not only C3, but with kappa and lambda too, because those are the light chains that are attached to the heavy chains that are part of the abnormal antibody. So it's usually, the pattern is usually IgA and C3 kind of dominant, maybe IgA a little bit predominant over C3, and then kappa and lambda as well.
Okay.
Yeah.
Yeah, I found C3 to be really variable.
Yeah.
But usually positive.
Yeah.
And then finally, so transferring over to the chat, we have a couple of the same things here. And then Parmjeet, our president, has commented on a couple questions. I have read that even so-called secondary IgA nephropathies have galactose deficient IgA. So can we not regard it as the same disease as primary IgA nephropathy, exacerbated by a second or third hit?
That's a possibility. I feel like this distinction between primary and secondary disease has a lot of overlap in a lot of different diseases. Even with, for example, I'm going to get off topic for just a second to answer Parmjeet's question. Even with primary and secondary membranous nephropathy, the antibodies, the anti-PLA2R and that anti-THS7DA, I was reading about that, and that someone was saying that one of the papers said that second antibody is seen more commonly in women and seen more commonly in people who have malignancies. So but my understanding is that a malignancy is the primary cause for secondary membranous. So if the antibody, which is supposed to be associated with primary membranous, is seen in people with malignancies, and how is it primary, right? So I guess my point is that the primary, secondary has a lot of overlap. It's sort of the old guard, the way we regard things and the way we talk about things in renal pathology is this primary, versus secondary FSGS, which has a lot of overlap as well. Not so sure that we can 100% rely on it all the time, but it's definitely something that I wanted to make sure I mention so that people have the right framework in case they hear it in the discussion with their nephrologist.
Yeah, I think we need to rethink our conceptualization of primary versus secondary, and it's definitely not, black and white. There's a lot of, overlap in that spectrum. So
yeah.
Yeah, good thoughts. Okay, so Parmjeet also says, should the MEST score be used for these cases of so-called secondary IgA?
What I tend to do is write a very detailed comment. I just had a case of IgA nephropathy where the patient for sure had liver disease, and it was one of those things where it was an atypical case. It had really bright IgA by immunofluorescence, but there were no deposits by electron microscopy, and I was like, that kind of sounds quote unquote secondary, because I know that they have a primary disease. I know that this is probably just secondary deposition. So what I did was I raised that issue in my comment. I raised that possibility in my comment, and I still gave a MEST score, but just kind of put both things in the comment and said, this is probably secondary onset, but for the purposes of classification, the MEST score in this case would be X, right? Because I'm not sure that I am aware that MEST scoring is specifically to primary IgA nephropathy, kind of like with primary versus secondary membranous.
Right.
So I think that a good, clear, and descriptive comment in your cases where you're communicating exactly what you're thinking is going on when the case is not straightforward, which so many cases are not. Like, I would love the 3 pictures I showed. I would love if all of my cases did exactly the right thing and worked the right way. But there's so many times when that doesn't happen, and we have to really just make sure we have good communication with our nephrology colleagues.
Right.
Yeah.
I completely agree. His last component of his comment and questions is prognosis of secondary IgA different from primary IgA?
Yeah, so I think, as I was mentioned, I think when it's kind of more, and as we talked about the overlap, but when it's kind of more of an established secondary onset, given the timing of proteinuria and hematuria in the midst of another primary disease, it's that treatment of the primary disease, if we believe in primary versus secondary, that usually lessens the severity of the secondary IgA nephropathy. So the outcome is it's going to have a very different outcome strategy, because you're not treating primary IgA, you're treating the disease, which is affecting the IgA deposition. Yeah. But I still use an M score. I just feel like I like it, and it helps, the nephrologist know, okay, so there's, some segmental scarring, and, it's probably due to the IgA and not like an overlapping FSGS on top of the IgA on top of the primary disease. So I think it just helps to illustrate the findings on the biopsy as well too. But everybody's different. Everybody,
Right.
And yeah.
Next question, and this one I grapple with all the time. In a case with faint IgA by immunofluorescence, do you consider it IgA nephropathy without EM results?
That's a good one. So I like to put everything into perspective. So if it's, instead of just going by just the fact that there's faint IgA by immunofluorescence, I want to know, what does my light microscopy look like? Do I have my mesangial hypercellularity? And if I have my mesangial hypercellularity and I have faint deposits, how faint are they in comparison to everything else? Is it fainter than C3? Is it fainter than the light chains? And then on top of that, there's no dense deposits. I kind of wonder in that case, in those cases like that. I will say that a lot of times when I'm stuck in that situation is on transplant biopsies where IgA has recurred in the transplant. And because they're being partially treated by the immunosuppression of just having a kidney transplant, a lot of times there's atypical deposition of the IgA nephropathy in that case too. So I struggle with that a little bit. Was this the donor? Is this a recurrence? And so again, it's just, you have to be very, very careful, have a good communication with your nephrologist and let them know, this is what I'm seeing, this is what I'm seeing, and help me, close the loop here with what's going on with the patient. So,
Right.
But that's a long answer, and I'm not sure I answered the question. I think if there's faint IgA deposition by immunofluorescence, I use my other microscopes to help me close the loop along with some clinical info.
Right.
Mm-hmm.
Excellent answer.
Mm-hmm.
IgA staining is frequently associated with lambda predominance in the light chains. Will you please comment?
My comment on that is that I agree. I agree. Usually we talked about, you see IgA, C3, kappa, and lambda. It's a little bit more lambda predominant. I'm wondering, and I'm sure that it's established somewhere, but just in my own anecdotal decade of looking at kidney biopsies and just taking it as this is what I see and not really looking deeper into it, I'm wondering if that abnormally glycosylated IgA antibody tends to just be more more lambda light chain restricted. I wonder if that abnormality with the sugars happens to be associated with a preponderance for lambda, and that might be part of it.
Right.
No, Cami? I don't know.
I think even normal IgA has a higher affinity for lambda versus kappa light chain, yeah. And I assume the abnormally glycosylated ones do as well. But
yeah.
But yeah, that's really the only glomerular disease I can think of where we do see lambda predominance. But I think it's just because IgA is the one heavy chain that really has a higher affinity for lambda.
Right. And it's not like that, it's not monoclonal, you know what I mean?
Right.
It's not that predominant, a little bit higher intensity, but not something where you have to worry about, oh my gosh, do I need to do a, SPEP and UPEP and look at all that stuff here. So yeah.
I use that sometimes when the IgA is a little bit faint and I'm wondering, is this a true IgA nephropathy or is this kind of non-specific? I always look next at the lambda, and it's like if there's lambda there, that'll kind of push me towards, it might actually be IgA nephropathy, but otherwise, yeah.
And also when I'm looking at immunofluorescence and I go in order and I pick B and it's negative, I pick up A and it's got some Mesangial staining. I'm like, okay, this is IgA until proven otherwise. So come on, C3, come on, lambda, let's do it. Come on, act right. So not to belittle it, but that's what the struggle is real for renal pathologists to try to figure out how to put all of these different pieces of information together to formulate one diagnosis that makes sense for the patient and makes sense for the nephrologist. So
right, absolutely.
Eat your patience with us.
Okay, you're not off the hot seat yet. We have more questions coming in.
Okay.
What happens to IgA nephropathy secondary to cirrhosis after a patient undergoes liver transplantation? Interesting. Does it resolve? That
is a great question. I don't know that there have been enough repeat biopsies I went to a session on IgA, our most recent American Society of Nephrology meeting, and there was a whole it was a virtual meeting. There was a whole sort of discussion about repeat biopsies and should you keep biopsying people over and over again to determine outcome. And the thought was that it's not favored and not necessary. So, and that's in primary IgA. So when you apply that to secondary IgA, patient has all this liver disease, they get IgA, it's probably secondary, then they get a liver transplant. I don't know that we have enough data in additional biopsies after the explant or after the transplant, and the manifestation of the secondary IgA in that setting to be able to say definitively if it still stays there. We don't do a lot of, I feel like in general, we kind of establish the diagnosis and then our nephrology colleagues take it from there and just manage based on kidney function. We don't do a lot of repeat, except for in the transplant setting.
Right.
Yeah.
Okay, how commonly do you see C1q staining with IgA dominant or codominant staining, and does it make you think of another pathology?
Part A, not common. I very rarely see that. And part B, if I do see it, like Dr. Haas said, yes, for sure, I do. I do think of another one. Am I still sharing my screen?
You are, yep.
Okay, yeah. So yeah, C1q staining is where I have to really kind of stop and look and dig around and find out if I'm ruling out lupus, if they're a component of that. The other markers on the immunofluorescence panel will help you with that. But C1q is one of those things that, for the most part, unless it's lupus, and very, very secondarily down the line, C1q nephropathy, C1q is usually negative for me. So I don't usually, I usually look at it and it's negative. If it's positive, then I'm thinking, like that maybe there's a component of lupus or C1q nephropathy.
Yeah. We've seen a little bit, sometimes in secondary IgA nephropathy. Yeah. It makes me think, like, I feel like I've seen a little bit of C1q staining sometimes in patients with liver disease when we're diagnosing their IgA nephropathy. So, yeah.
And it also depends on how you interpret your immunofluorescence. You know what I mean? Like, I never say negative. Very rarely do I say negative, because there's always a little bit of degree of baseline, sort of normal / baseline staining in immunofluorescence. So if someone who just calls everything negative, if it's not out of baseline, sees a little bit of staining, then they might interpret that as kind of positive. But generally speaking, things have to be high intensity. So we score our immunofluorescence from 0 to 4+. And I always kind of call things kind of trace, because I just hate to say, it just doesn't seem right. If I'm seeing staining and I'm saying negative, I feel like I have to say something, but that's just my little idiosyncrasy. Yeah.
Absolutely. At what point does lambda predominance in IgA worry you for something monoclonal?
If there is a discrepancy of staining between lambda and kappa more than one intensity, you know what I mean? If kappa is 1+ and lambda is kind of 1 to 2+, I don't worry. If kappa is 1+ and lambda is 3+, then I kind of think that this maybe, let me take a look, let me just document this and do a little bit more digging. So it has to be a big difference in intensity for me.
This must be a common problem that people encounter, because there's another question. If you have a case with IgA and C3 positive IF and restriction of light chain, what's your diagnosis? IgA nephropathy, monotypic IgA nephropathy? So this is coming up a few times in the chat.
Yeah, that's a question that's hard to answer out of a real scenario without a real kidney biopsy and real clinical history and all of the other light microscopy and things because all of those things weigh in, right? All of those things are important in the diagnosis. So I think that generally speaking, if it's pretty consistent with IgA nephropathy, IgA, C3, maybe a little bit lambda predominance over kappa, I'm okay. Any sort of issue with light chains, I definitely kind of stop, drop, and dig for a little bit more information to kind of see what's going on before I call it anything, because I want to make sure that I'm not missing an MGUS or some other sort of, monoclonal issue.
Right.
It depends on the situation. Yeah.
Right. That's when you contact your nephrologist and say, please get an SPEP and a UPEP.
Exactly. A lot of times they've already done it.
Right.
Sometimes like, ooh, maybe I should have looked at that before the biopsy. So it depends on your time, what your time. If you got a lot of biopsies, you can't do a deep dive before you look at every one. You kind of
right.
cycle them through the best you can. So.
Okay, so I know we're over our time. I just wanted to say a couple of other people said, wonderful conference, outstanding talk, Carla, thank you. Parmjeet did mention, I know that donor-derived IgA nephropathy resolves after transplantation, so he expects the same in cirrhosis, so That's helpful. And then one last question for you. What is the true role of complement in the pathogenesis of IgA nephropathy? Not only in the aggressive and crescentic forms, but in just a typical IgA nephropathy. What is the role of complement?
I'm sorry, say that. Was that in the chat? I just opened the chat for the first time and there was like 30 messages in there. I'm sorry.
Oh yeah, no, it's the last question is the fourth one from the bottom. What is the true role of complement in the pathogenesis of IgA nephropathy, not only in aggressive and crescentic forms?
True role of complement. So I think that question can be best answered by two things. So first of all, as I mentioned, I don't know what you mean by true role, but complement is recruited and activated when antigen and antibody complexes deposit. So the role, like it would be in any other antigen antibody, this happens to be an autoimmune scenario, but like where it'd be anywhere where you have antigen antibody reactivity would be to recruit cytokines and recruit other inflammatory cells into the area of interest. So it's not really specified by being aggressive or non-aggressive forms of IgA. I see complement in the C3, not C1q, whether there's crescents there or not. So I think that the role of complement is kind of as I described, it's a mediator of inflammation. And unfortunately, in this scenario, it's against ourselves, but it's what's causing the disease, the glomerular injury, the proteinuria, and the hematuria. I would say that what some of the studies that I've done with IgA nephropathy has been in the transplant setting, recurrences, and we looked at C4D in recurrent IgA, not in the assessment of antibody-mediated rejection, but just to see if that complement mediator was positive by immunohistochemistry in transplant biopsies where they had recurrent IgA nephropathy. And we got to the point where we said, yes, it's there and it's positive, presented it at a meeting. And then a lot of people at the meeting kind of commented and said, well, where are you seeing your staining? Are you seeing it, in the mesangial areas? Are you seeing it in biopsies with crescents, like kind of better classify where you're seeing the C4D staining? Because not in the peritubular capillaries, right, but in the glomeruli, and correspond that with the light microscopic findings. So if you're seeing C4D deposition in glomeruli, is it in biopsies that by light microscopy have mesangial proliferation or have crescents and that kind of thing? So we got to the point where we're seeing it, we're seeing C4D, but needing to classify exactly where it's depositing. All we know is that it's in the glomeruli, not in peritubular capillaries, and associated with recurrence of IgA in transplant biopsies. So yeah, I think it has, you know, a very definitive and well-established role in antigen antibody complex mediated disease.
Well, wonderful. You've addressed everything. And again, thank you so much for your time and effort. And this was just fabulous.
Thank you. Thank you. I wish that we had more questions from patients. I don't know how I can tell if someone's a patient or not. Parmjeet is obviously not a patient, but it was really, really directed towards patients and sort of more just a simplified version of it so they can understand their biopsy reports. So, yeah. Thank you, Ben.
Okay, yeah, thank you very much, Carla, for the fantastic talk, and Cami for moderating that very lively Q&A session. I think this went really well. If any participants or any viewers of the recording have any follow-up questions afterwards, please feel free to direct those to us at the Renal Pathology Society, and we'll make sure they get to Dr. Ellis.
Okay.
So just one final announcement. Our next patient-centered webinar series lecture is scheduled for March 5th with Dr. Anthony Chang from University of Chicago, and he'll be talking about the pathology of lupus nephritis. So with that, I'd like to thank you all for your interest and participation, and yeah, we'll see you at future webinars.
Thanks, Ben, and thank you so much, Carla.
You're welcome. Thanks, everyone, for attending. Appreciate that. All right, I'm going to stop sharing now, guys. Okay. All right.